So welcome to Biomechanical Standing Posture Analysis. Our learning objectives for this unit are such that at the completion of this unit, the student will be able to describe normal alignment and anatomical location of the center of gravity, describe the line of gravity and related moments created about each joint axis during normal static standing. And remember that moments are potential torques. So you're asked to be able to describe where the line of gravity is and thus its related moment created about each axis during normal static standing. Describe the anatomical structures that function to counteract the line of gravity potential torque or moment produced at each joint through the kinematic chain. And in particular, we're looking at the ankle, the knee, the hip, and the spine. Additionally, you're asked to be able to recognize and then discuss common postural faults noted in individuals in different ages or having a variety of impairments. And then you should have the ability to discuss the effects of skeletal malalignment on joint structure and the energy cost requirements during static and dynamic functional activities. So we'll just begin with a few talking points. The first is, why do we even care? What's important as it pertains to our knowledge of standing static postural analysis? Well, ultimately, with your patients, you'll be assessing structural alignment, structural integrity, and their posture, both standing and sitting, almost on a daily basis. And it is in our attempt to do this to try to determine the stress that is placed throughout the body or on the body, bearing in mind that stress is load, and also the strain that that stress then causes, strain being the deformation. Excuse me. We want to know if the loads are normal. Do they appear to be normal loads on the body, or are they aberrant or abnormal loads? And then ultimately, if we know what is normal at each joint, what the normal load should be, where the load should be placed, be it through the joint axis, anterior to the axis, posterior to the axis, wherever, then we can distinguish abnormal. So I'm a firm believer that if we can identify normal kinematics, kinesiology, biomechanics, we can then distinguish abnormal. And then ultimately we can help determine the contributing factors to the chief complaint of the patient, be it a tension load intolerance, compression load intolerance, or combination thereof. How would you define optimal posture? What do you think optimal posture is? What would it be defined as? You may be picturing in your mind or beginning to describe in your head a posture that is upright, a military style posture, if you will, with a retracted C-spine and shoulders back, shoulder blades kind of pinching together. And that is all true. That is kind of the position, and we're going to go through that in a little bit here, slide by slide, as to how the joints should be aligned. But additional to that is the notion that optimal posture should be defined as being the most energy efficient position as is possible. And to be energy conserving or energy efficient, we want to be in a posture such that we have the least amount or decreased amount of muscle activity. Now, to do that, to have the decreased amount of activity, we have to consider a compression force through the joints versus a force that is applied off center of the joint axis, therefore torque occurring. So as you see these blocks aligned here, pretty well stacked on top of each other. If you looked at the center of mass of each of the blocks, the block with the L, then the E, the A, the R, and the N, they're relatively centered directly on top of one another, such that there is predominantly a compressive force applied to them, one on top of the other in stacking format. Therefore, there is no really torque to overcome, if you will. It doesn't appear that any one of those blocks is going to fall off of the other anytime soon. Whereas opposed to this picture, where you see the blocks off center a bit, A, B, C, it wouldn't take much to apply a force to block A, or perhaps a pretty strong wind to come in to blow off A off of B, or B off of C, because they are applied off center of one another. Therefore, there's a moment or a potential torque for A to fall into in this view, a counterclockwise direction. B to fall relative to a clockwise direction on C. So back to defining optimal posture, we're looking for decreased muscle activity in the body, and we can do that by increasing compression force. So to the figure to the right here, the greater the compression force through our bony segments, through the joints, the least amount of torque there is that we have to overcome internally through muscle activity. Therefore, we are more energy efficient. Additionally, in defining optimal posture, we're trying to keep our center of mass over our base of support. And as you know from earlier discussions in the course, if we can maintain our center of mass over base of support, we enhance or improve our stability. Additionally, for optimal posture, the third definition to it, if you will, is the ability for us to maintain our eyes level, our ocular system level, as well as our vestibular system level. This was described by DeFabio back in 1997, where our head vertical, our head upright, we somewhat live as a human species subservient to our ocular system and vestibular system. And it really boils down to a flight or fight response, whereby for safety of our being, of our body, our eyes level to the horizon, our vestibular system for balance and equilibrium level aids in our flight or fight response. So it is a safety mechanism, if you will. As far as the static and dynamic piece goes, to a talking point, static balance or static posture could be a standing posture where you're not moving, seated posture perhaps as you're listening to this now, lying down, kneeling, etc. So static posture could be just a still position, but it doesn't just mean standing. It could be a varied positional opportunity for your body. Whereas dynamic posture is or includes activities such as walking, running, jumping, throwing a ball, etc. there. Static forms our basis for understanding dynamic. So we really begin there and then we build beyond that in a dynamic realm. Not unlike how we've been talking about and working on static biomechanical analyses with our phases of motion as opposed to looking at it in dynamic concert. So again, static posture would be standing, sitting, lying, kneeling, etc., whereas dynamic would be activities such as walking, running, jumping, and throwing. Bipedal versus quadrupedal gets into a posture of 2 feet versus 4, obviously. Us being a bipedal species, we want to be conscious of what that does to us. Well, our erect posture has its benefits, right? So because we're a bipedal species, our erect posture allows the following things. It allows for upper extremity usage, right? We're not walking around on our hands and feet, so upper extremities can be used for function. Additionally, being bipedal actually compromises upper extremity function in the presence of crutches. So if you had to use bilateral crutches, be it axillary crutches or loft strand crutches, it would compromise our function quite a bit, being that we're a bipedal species. The disadvantages further is that being bipedal, it increases the work of our heart. Our heart is elevated, it's higher away from the supporting surface. So due to the pull of gravity, the drawing of pooling of blood down to the feet, the challenge of our venous system, venous return of blood flow is present. So the disadvantage of being bipedal is it increases the work of our heart. Additionally, it increases the stress and therefore then strain on our vertebral column, our pelvis, and our lower extremities. And then lastly, ultimately compromises our stability. As we talked earlier in the course, the higher your center of mass, which occurs in a bipedal species, it compromises our stability. If you look at quadrupedal, quadrupedal has increased stability opportunity because if you're an animal such as a dog or a cat or any quadruped animal, or us on all fours, our center of mass is closer to the supporting surface, so as you know, that increases our stability. We have a lower center of gravity, therefore we have a greater opportunity to be stable. Our base of support is greater. As you know, we draw our base of support around all points of contact on the supporting surface, but we have compromised function. So if we were a quadrupedal species, we wouldn't be with upper extremities opportunity for them to be free to function for us. As you know, our center of gravity or center of mass is approximately at S2 or just anterior to S2 with a relatively small base of support. So it's at this time when I have this talk year to year with the students yourselves that I kind of pause and in somewhat of amazement that we can even walk in its entirety. I mean, think about how high our center of mass is, and you know, the center of gravity is just anterior to S2, and we have a very small base of support, and through our gait cycle, as much of our gait cycle, we're just on one extremity. It's amazing that we're not often just falling down, that we can even stay upright as a species. When we look at where the stability comes from, the stability comes from primarily our bones, joint capsules. Remember, capsules are dense connective tissues, as well as our ligaments. If you had your druthers and you could say, well, I want to have a stable body and upright posture, would you want that stability to come primarily from your bones, capsules, ligaments, or would you want your stability to come from muscle? So perhaps pause this for a second and think about that, and then hit play when you're ready with your answer. Well, hopefully you were thinking the former here, that you would want your stability to come from bones, capsule, and ligaments over muscle. And this goes back to the earlier talking point of how do we define optimal posture. And one of the definitions came from the notion that we would want to be most energy conserving. So to be energy conserving or have energy conservation, that comes in the form of not using skeletal muscle. Anytime you're using skeletal muscle, you're burning fuel, you're burning energy to maintain that posture, and therefore it's not very energy conserving. So as you'll see in the upcoming slides, our optimal posture comes in the form of bones, capsules, and ligaments, primarily those being inert structures, providing us for stability over the muscle. So the answer again lies here, that to be most stable, we want to be energy conserving or have decreased energy expenditure. Maintaining stability of the body in response to forces placed on it. I've used the term for you in the past of a perturbation. Any perturbation is an external force, a bump, a push, a pull, something of that nature. So we're trying to maintain our stability of our body in response to all these forces that are placed on it throughout the day. It could be wind, it could be a G-force, it could be a push or a pull or something of that nature from a person or an object that contacts you. We have to rely on sensory, we have to rely on mechanical systems, and there are things such as sensory perturbations and mechanical perturbations. A sensory perturbation is essentially an alteration of your visual input, such as when you close your eyes unexpectedly. And we test this with our patients all the time. We challenge or test their balance in standing and sitting through perturbations. One is an eyes open versus eyes closed opportunity, and see how they sway and if they're able to maintain that posture. So sensory perturbation would be altering visual input, such as closing your eyes. Think about yourself, getting up in the middle of the night, you have to go to the bathroom, and kind of clambering your way toward the bathroom, holding onto walls and bumping into doors and stubbing your toe and things like that as you're making your way to the bathroom. Those are perturbations because you've lost your visual acuity. Mechanical perturbation is due to a direct change in the relationship of your center of gravity to your base of support, due to your body segment movement or the entire body. So different than the sensory, the mechanical is a direct change in your center of gravity away from your base of support, some body segment change. You've flexed your knees beyond an ability to keep your mass over your base of support. You flexed your trunk, so you're falling outside of your base of support. So that's a mechanical perturbation. For some patients, breathing, just as odd as that sounds, just the ability to breathe is enough of a perturbation that can affect their balance. Patients with chronic obstructive pulmonary disease or emphysema, their challenge in breathing, cystic fibrosis, often compromises their balance. So that's concerning. If you look at a multi-system contribution for us to maintain postural control, we can't lose sight of our central nervous system and its ability to identify postural change in positions. I've already mentioned our visual system. Our ability to see certainly helps that. And the vestibular system, our righting reflexes, our equilibrium reflexes are very important. And then the musculoskeletal system, we have our afferent joint receptor input from the peripheral nervous system, our proprioceptors in our joint capsules and things of that nature that send signals to the central nervous system, to the brain, to tell us where our joints are in space. So, you know, your patients will have compromise of their posture and balance with any one or any four of these in any combination that will affect their balance. And we need to assess that to see where it's coming from with our patients. So how do we respond to postural control? We can do it from a reactive standpoint, or we can do it from a proactive standpoint. So reactive or reactivity or compensatory responses speak to responses that occur as a reaction to the external force that displaces our center of gravity. So it's already happened. We've been perturbated. We're reacting to it. Versus proactivity, being anticipatory, means that the anticipatory response occurs of internally generated destabilizing forces, such as, you know, raising an arm to catch a ball or bending to tie your shoes. These are activities that we do kind of innately. So, you know, if you're sitting there and, you know, or say you're in the stands of a baseball game, we have baseball playoffs going on right now, and you got to pay attention, right? So if you got good seats and you're in foul ball territory, you got to pay attention. And you'll see this time and time again, and thankfully so people don't get injured. There's a proactive or anticipatory response that you reach up, again, to save your life in some instances, or the person next to you, and you grab a ball or catch a ball. You've yet to be perturbated by the ball. You didn't wait for the ball to hit you in the face and then say, oh, I better do something about it. You put your hand up and you grab the ball in anticipation or being proactive. The, again, reactive compensatory response would be that, you know, you're walking down the hall and somebody bumps into you. Well, that perturbation has already occurred. How do you react to that? Hopefully there's some stepping mechanism. You reach for the wall, you step to the side, you step in the direction of the applied force, as we've talked about, and you quote unquote catch yourself, you know, from falling. So these are the two responses that that can often occur in the body. Task specific and vary with magnitude, velocity, and direction of force and initial posture of individual at the time. The task specific opportunity for postural strategies or synergies deals with how fast that force is applied, how much the force is applied, and the direction. So all of this kind of comes together. So an example would be that you're walking down the hall, you yourself, you know, healthy, fit, young, and so forth, and you know, somebody mistakenly, inadvertently bumps into you. Well, that bump that occurs to you is again going to cause a reactive response, a reflexive response, and hopefully again you're just stepping to the side. You're maybe putting your hand out for the wall, but not much happens to you, and you proceed on your way. Versus that same magnitude of force with the same velocity and in the same direction of potentially an aged individual, a geriatric individual who has some systems that are compromised. Reflexes are slower, visual acuity is compromised. Maybe they have a vestibular balance disorder. Proprioception is compromised, such that that same magnitude, velocity, and direction actually causes that individual to fall to the ground and break a hip. Okay, so, you know, we look at the fall risk in the aging, and this is a big part of our profession as PTs, that we look at that. There's ways to calculate that, to determine it, to ultimately predict it. But we look at that because, as we know, the morbidity rate is pretty high post, you know, fractured hip. But that's just one example. So we really got to take into consideration these variables, and does the patient have the wherewithal and the body makeup to counteract that perturbation or not? Well, there's ways that we can do that, and we can do that through an ankle strategy, or we can do that through a hip strategy. So let me give you the language that this applies to. Then on the next slide, actually embedded 2 slides that are new to you that you don't have in your notes at this time, but I'll provide to you in class. An ankle strategy speaks to discrete bursts of muscle activity, either anterior or posterior. But note that the muscle force, the muscle generation, the muscles that turn on occurs, importantly to you, in a distal to proximal standpoint, or a distal to proximal pattern. Okay, so your feet remain fixed on the ground, and let's say that there's a perturbation. You're just standing there, and you get perturbed, either a external force posterior to anterior or an external force anterior to posterior. Well, the muscle activity, because your feet are fixed on the ground, is going to occur in a distal to proximal orientation, meaning your foot and ankle musculature will turn on first to check that motion, to counteract, to be a check rein to that force, followed by your leg musculature, followed by your thigh musculature, followed by your hip musculature. So it works distal to proximal up the chain. So see if you can follow this scenario. Let's say that you're standing upright and somebody pushes you from the front backwards. So you're pushed backwards, so essentially an anterior to posterior directed push. And the magnitude of that push is not too great. As somebody goes to push you backwards, hopefully you can kind of catch that by just turning on these muscles distal to proximal. What's actually happening is that external force, that external perturbation, is challenging your ankle position. And it's essentially attempting to push your ankle into plantar flexion. So what you would do is you would turn on innately, instinctively, reactivity-wise, you turn on your ankle dorsiflexors, because Newton's third law always applies, action, reaction. So you're turning on your tibialis anterior, for example, as an ankle dorsiflexor, your extensor hallucis longus as a secondary ankle dorsiflexor, and you may actually turn these muscles on, kind of up the chain. If it goes up to the knee and the hip, you're actually being pushed into a hip extended posture, so your hip flexors might turn on, and so forth. If just the opposite happens, if you're pushed forwards from behind, so now you're standing still, somebody's behind you and they push you, they give you a little shove in your back. Well, as they shove you in the back, it's not too much of a force that you have to step forward in the direction the force is applied. You're going to kind of check that push by this ankle strategy. So now, as you're being pushed forward, the moment or potential torque by this external force is attempting to dorsiflex your ankle. So again, action, reaction, you turn on your plantar flexors. You're pushing to the ground, if you will. You might go up on your toes. And as you go up on your toes, you're essentially plantar flexing your ankles. If it works up the chain more proximally, again, opposite of what we just did, you're being pushed into hip flexion. So you would turn on your hip extensors, gluteus maximus, gluteus medius, and so forth to check that. You might actually extend your trunk. The external force is flexing your trunk in an anterior direction. So you might turn on your paraspinals. You might turn on your rector spinae, all the way up to the neck extensors, and so forth. So that's an ankle strategy, and the ankle strategy works when the magnitude and velocity of the force is on the lower side. So think about a low amount of force, slow push, if you will. You'll be able to check that through this ankle strategy, be it forward or backwards. Defining hip strategy now, we have discrete bursts of muscle activity on the side of the body opposite to the ankle pattern. And now this is occurring in a proximal to distal pattern of activity. Okay, a proximal to distal. So it's just the opposite. Ankle strategy was distal to proximal. Now hip strategy is proximal to distal. This is often referred to as a stepping strategy. So here now, the force, the magnitude is much greater, the velocity is greater, and such that you might have to step. So let's go back to the ankle strategy that we did right at the onset, being pushed backwards. So somebody is standing in front of you, and they attempt to push you backwards with greater magnitude, greater velocity. you might not be able to just turn on those muscles at the foot and ankle in a distal to proximal direction perspective. You may have to step backwards. Again, we're always going to step in the direction the force is applied to maintain our stability. So if you can imagine a pretty significant shove anterior to posterior, you're going to extend your hip. One leg's going to step backwards. If somebody's behind you and they're pushing you forwards, just the opposite would happen. If the force is excessive, it happens too quickly, and you cannot complete an ankle strategy to check it, you'll step forward, you'll flex your hip and step forward so that your base of support increases in the direction that the force is applied. Okay, so again, the young versus old comes into play. So the younger, healthier person with their systems all at play, you might just get one simple step of a hip strategy to check it. An older individual, geriatric population individual, or somebody with significant compromise of these systems that check our balance, you might have multiple steps. These multiple steps might be shorter or less in distance than this younger individual. So it might step multiple times and unfortunately might actually fall because they don't have the reflex capability nor the strength to stop that. So this is one of the slides, and the next slide is the second that you don't have. I'll provide this to you, but here's an ankle strategy where the perturbation, again, is slow. It's of low amplitude. We're maintaining the feet contact with the surface. We're getting a recruitment of muscle activity, once again, distal to proximal. Head movements are going to be in phase with the hips. So what we're seeing here is an anterior to posterior directed push. The perturbation is trying to create ankle plantar flexion, so the person would have to kick in or turn on their tibialis anterior, which is a primary dorsiflexor of the ankle, extensor hallucis longus that extends our great toe. It's an extrinsic ankle muscle, so it also can secondarily dorsiflex the ankle. These would turn on to stop that plantar flexion moment. Hip flexors, iliopsoas, would turn on to pull forward and so forth. Here's a hip strategy figure, which shows the notion when used when the perturbation is, again, fast or large amplitude. Surface could be considered to be unstable or shorter than the feet dimension. Muscles, once again, are recruited proximal to distal, and now the head movement is out of phase with the hips. So you can see the whole attempt here is to keep center of mass over base of support, right? Center of mass over base of support. So in this instance, what would end up happening is we would move in opposite directions. So if the perturbation was anterior to posterior, we're attempting to create plantar flexion of the ankle as the external force is applied. Dorsiflexors kick in to stop it, but if it's not enough of an ability to do it, there would be flexion of the trunk to keep the center of mass over the base of support. Just the opposite, the figure to the background here would be a P to A force. So somebody's pushing posterior to anterior, that would try to create dorsiflexion of the ankle. This person here would kick in their plantar flexors to stop it, but if it's not enough, they may extend the hips and extend the trunk to, again, keep center of mass over base of support. As I previously stated as well, there could be a stepping strategy here too if they cannot check it and keep their feet stationary. So the stepping strategy here for this one in the foreground would be flexion of the hip. They got to step forward. Strike that. This picture in the foreground is showing an anterior to posterior directed force. If flexion of the hip and the trunk can't check it, they may need to step into extension. The one in the background is showing a P to A force. If they can't check that perturbation and keep their center of mass over their base of support with hip extension and trunk extension, they'd ultimately have to flex their hip and step forward. All right, so we'll press on with defining for you combined action line. Combined action line speaks to the ground reaction force vector and gravity in a combined fashion. Okay, so our ground reaction force vector is that force that is applied. Remember that ground reaction force is applied at the center of pressure and ultimately projects toward the center of mass of that individual. The pull of gravity obviously lands at the center of mass coming down to the supporting surface. So when we combine the ground reaction force pushing up gravity pulling down, that is referred to as our line of gravity. The point of application of ground reaction forces, I just said, is at the COP, the center of pressure. Now, if we're in unilateral stance, we would have this COP, the center of pressure, in the mid portion of the foot, assuming that you have equal weight bearing from heel to toe. So if you're standing on one leg and your center of mass is equal between heel and toe, your COP, your center of pressure, would be at the center of the foot, projecting up towards your center of mass. If your center of mass is anterior, let's say you're leaning forward on one leg, now the COP is out more to the forefoot, out to the toes, and once again projects towards center of mass. You're leaning back, it's toward the heel. I think you get the idea. If you're in bilateral stance and you have equal weight bearing left to right, where do you think your center of pressure would be? Center of pressure should be between the 2 feet. So you would draw a point of application not even on the feet themselves. It would be between the feet, projected up towards your center of mass, because you have equal pressure left to right. As a human species, we actually have a constant sway to our body, and you often don't even think about it. So if you're standing, maybe just stand right now as you're listening to this. If you're standing erect and upright, we have a constant changing of our sway to the body. Secondary to our vestibular system, our proprioceptive system, any perturbation that occurs due to air, ground movement, things of that nature. So it's not out of normal or out of question that we have a position whereby at any given time we have a 12-degree sagittal plane change, that's anterior to posterior, and a 16-degree frontal plane sway side to side. And this was applied when we're standing with a relatively 4-degree toe out position. So normal standing position, it's called the Fick angle, F-I-C-K. The Fick angle is where we stand and our feet are pointed outward just a little bit, not too excessive, about 4 degrees, maybe up to 6 degrees. So with a normal 4-degree to 6-degree Fick angle, at any given time, we'll sway anterior to posterior 12 degrees, side to side, medial to lateral 16 degrees. If the line of gravity is through the joint axis, directly through the joint axis, how much torque do you think is going to be generated by gravity? What is the moment? What is the potential torque of gravity if it falls directly through the joint axis? Pause this if you need to think about it. If you're there already, hopefully you know that that blank should be filled in with the number 0, right? 0 torque. Because what is torque? Torque is a force multiplied by a distance. If the line of gravity falls directly through the joint axis, what is the distance away from the axis? The distance is 0, right? If it's going through the axis, the distance is 0. Any force multiplied by 0 gives us 0 torque. So this goes back to the notion that this is ideal. If we can have optimal posture whereby the line of gravity falls through a joint axis directly, there is no external moment due to gravity, there's no external torque to have to overcome, and therefore we're more energy efficient. So I have this in yellow for you in larger font and text and so forth to really send a strong message to you. So as we move forward through these remaining slides, this is an important thing to remember. If the line of gravity is anterior to the joint axis, the moment or the potential torque of gravity is anterior motion of the proximal segment. Remember, a segment is a bone. 2 segments come together, join in the middle, right? So if the line of gravity falls anterior to the axis, it wants to move the proximal segment, whatever the proximal bone is, in an anterior direction. Now, why are we focusing on the proximal segment? We're doing so because standing erect posture is a closed kinematic chain task, right? Remember your definitions, closed chain, distal segments are fixed. So your feet being fixed to the ground, we're going to have a proximal segment of a joint moving on the distal segment of the joint due to the pull of gravity, okay? The opposite definition occurs if the line of gravity is posterior to the axis. So as we go through these subsequent slides, if the line of gravity falls posterior to the axis of rotation, the moment or the potential torque is posterior motion of the proximal segment. Okay, so we're looking at alignment, the line of gravity, and we're looking at sagittal plane activity. So we're either going to get an anterior directed motion, typically referred to as flexion, or a posterior directed motion, typically referred to as extension. And I say typical because in the upcoming slides you're going to see a new term that you may not be familiar with. The plumb line that we use represents our line of gravity. So this, in prep of next week's lab, this coming Tuesday's lab, is this podcast, and what we're going to do in lab is we're going to assess standing posture. So as you enter lab next Tuesday, you're going to find that I have plumb lines, essentially strings hanging from the ceiling with a weight at the bottom, or what's called a plumb bob. And so a plumb line is essentially representing the line of gravity. It's going to hang from the ceiling as close to the ground as possible, but not touch the ground. Therefore, gravity is going to allow it to be pulled to a vertical position. So that plumb line is going to represent our line of gravity. And then you as students, and then ultimately your patients in the future, can line up next to the plumb line to see where gravity is falling relative to the major joints in the body, and to ultimately determine this here. Where is line of gravity falling? Is it falling anterior to a joint axis? Is it falling posterior? Therefore, is there a flexion moment? Is there an extension moment? And then we can talk about, who's the check rein structure. So here's a representation of that in figure, and this would be optimal. So this is demonstrating optimal posture standing alignment. Here's our plumb line hanging from the ceiling. Here's a line of gravity. And so what we're going to do in the subsequent slides is talk about distal to proximal. Where should gravity fall relative to the ankle joint? Where should gravity fall relative to the knee, the hip, lumbar spine, thoracic spine, lower cervical, and upper cervical? Okay, but this gives you a representation of optimal standing posture. So sagittal plane, which is a lateral view, or we're in the MTAL axis, as you know, we always want to stand in the axis about which a plane of motion occurs. If we start at the ankle joint, or talocrural joint, the line of gravity should be just anterior to the lateral malleolus. Okay, so when we position each other in lab this week, or you position your patients in the future to assess their standing posture, this is the only joint that we have to fix. This is the only joint that we have to set up or align to the plumb line. After we do that, then we just look up the chain, knee, hip, pelvis, lumbar, thoracic, cervical, and see where do those segments fall relative to our plumb line hanging from the ceiling. But we have to establish or set up the ankle position. So where gravity should fall, the line of gravity should fall, is just anterior lateral malleolus. So there's a sliding scale here of definition, right? What does anterior mean? How much anterior? And I'm giving you the phrase just anterior. It literally is a centimeter and no more. So when we align each other up to the plumb line, you're going to have your peer, your patients line up. You're going to get down on the floor and you're going to say, step forward a little bit. Nope, step back. Get yourself just right. And you want it such that the line of gravity is just anterior to our lateral malleolus of the fibula. And so you'll get down there, you'll palpate the fibula, and you'll get them to line up. So you're about a centimeter, that line coming down anterior to the malleolus. So what does that mean when we do that? If you align it as such, that would suggest that we have a dorsiflexion moment at the ankle. Okay, so let's just pause with that for a second. So why, when the line of gravity is anterior to the lateral malleolus, is there a dorsiflexion moment, or again, a dorsiflexion potential torque due to gravity? Well, let's go back to this slide here for a second. If the line of gravity is anterior to the joint axis, well, we just set that up, didn't we? We put the line of gravity just anterior to the ankle joint axis, a centimeter anterior. Therefore, the moment is anterior motion. Gravity is in a position to create a potential torque, creating anterior motion of the proximal segment. Well, what's the proximal segment of the ankle? Go back to this one. The proximal segment of the ankle, or segments, is our tibia and our fibula. If our tibia and fibula move anterior on a fixed foot, you're actually closing the gap here of the foot and the anterior surface of the leg. That would be dorsiflexion, right? So dorsiflexion coming together, flexion is coming together. So if tib, fib move anterior, that's a dorsiflexion moment. Well, that's the first part of this. Then what's this latter part? Well, Newton's always in the room, as I said many times. Newton would say to you, Newton's third law applies, action, reaction. So if you're standing upright and you're not falling forward, you're not falling down, you're counteracting the pull of gravity into dorsiflexion, you must do that through the means of plantar flexor musculature. And in particular, our soleus counteracts that. So if you recall for a moment the muscle mechanic discussion on that podcast, there was discussion about the soleus being a tonic muscle or a postural muscle. The soleus, remember, was chock full of type 1 muscle fibers, which are rich in oxygenation for energy. So our soleus over the gastroc, because gastroc is a type 2B muscle, soleus is going to contract pretty much all day if you're standing. Soleus's job is to work overtime to prevent this dorsiflexion moment due to gravity such that we can stand upright. So we have action, if you will, due to the pull of gravity, reaction, if you will, to soleus counteracting that. Okay? The word counteracting refers to a check rein structure. Check rein capabilities is a stopping structure. Who's stopping it? So when I say soleus counteracts this, soleus is the check rein. It's the muscle that's stopping the dorsiflexion moment. So here it is in a schematic showing that, again, there's a dorsiflexion moment. This is our line of gravity coming down right here. Okay, oops, excuse me. A line of gravity coming down, and the line of gravity again is just anterior to the axis of motion at the ankle. So this would be your lateral malleolus, and we're about 1 centimeter anterior. So in that the line of gravity falls anterior, wants to pull the proximal segment anterior, that's tibia and fibula. So there is a dorsiflexion moment due to gravity, which has to be counteracted or checked by our soleus. All right, hopefully that made good sense to you. If not, maybe rewind and go back and re-listen, because moving on, it's just the same type of concept. If we look at the knee now, so again, we've aligned this line of gravity at the ankle, and now we just look up the chain. We look at the knee and we say, now where is the string of this line of gravity relative to the knee joint? If you have optimal posture, remember we're teaching you normal, and if you know normal, you'll understand abnormal. If the line of gravity is normal, it should be anterior to the axis of the knee. So think about a second. So if it's anterior to the axis of the knee, by definition, the line of gravity wants to pull the proximal segment anterior. Proximal segment is the femur, right? We got femur and tibia making up our knee joint axis. So what would the moment be? What is the potential torque due to gravity? If the femur is being pulled anterior, that ultimately is attempting to create extension. Femur anterior is an extension moment at the knee. If there's an extension moment at the knee, we need something on the posterior side of the knee to counteract it. But look at this. How nice is this? It's actually not the hamstring muscles. We don't need it to be. We can use an inert structure, a non-contractile structure, that being the posterior joint capsule. Posterior joint capsule is a dense connective tissue structure, no actin and myosin contractile proteins within, no energy expenditure, if you will, need. So in that there's a extension moment to the line of gravity, we can use our posterior capsule as the check rein and not have to use muscles to stop that. The soleus actually has been shown to also contribute due to its posterior pull on the tibia. So that this applies to up here, that the soleus, remember, is contracting to stop the dorsiflexion moment at the ankle. It clearly is a plantar flexor, and if it's trying to pull the tibia posteriorly because it attaches to the tibia, that's promoting check rein capability, trying to pull the tibia posterior and prevent the extension of the knee. So we can see that here, that we have the line of gravity falling anterior to the axis of the knee. If it's anterior, evident by this arrow, it's showing that there's an extension moment to the knee. Femur wants to be pulled forward. Ideally, we have the posterior capsule here as a check rein to counteract that. If we move up the chain now to the hip, what's normal at the hip is the line of gravity should be posterior to the axis, okay, posterior to the axis. So just in quick review, We had anterior at the ankle, we have anterior at the knee. Now we should be posterior to the axis at the hip. What we can use, thankfully, because it's a readily palpable structure, is our greater trochanter. If you palpate your patient or yourself as you're doing this, your greater trochanter should be in line with the line of gravity. Well, due to the anatomical alignment, our greater trochanter is actually posterior to the axis. So if the line of gravity is falling through the greater trochanter, trust that that's posterior to the axis of rotation. Okay, so what does that create? By definition, that creates a posterior rotation of the pelvis. Well, this might be new terminology to you, to some. Remember, we're talking about proximal moving on distal. Well, what makes up our hip joint? The hip is made up of the pelvis and the femur, right? Pelvis and the femur. But because we're in closed chain, it's a proximal on distal movement allowance. So if the pelvis moves posterior, the term is posterior rotation of the pelvis. Guess what? Posterior rotation of the pelvis equals hip extension. So if you're fixed and you posteriorly rotate your pelvis, you're essentially extending the hip. But it's called posterior rotation of the pelvis and not hip extension because your femur didn't move. So it's just what bone is moving on what, and ultimately what do we call it? So we would say that there again is an extension moment. So posterior rotation of the pelvis equals hip extension. So the line of gravity is trying to create hip extension. And look at, once again, you don't see muscles here. Hip extension does not need to be checked by a hip flexor muscle, does not need to be checked by the iliopsoas. It can be checked by pretty darn strong ligaments. Your iliofemoral ligament, going from your ilium to the femur, pubofemoral, pubic symphysis to femur, ischiofemoral, ischium of the pelvis to the femur. These are strong ligaments on the anterior margin of your hip, and they would need to be anterior, wouldn't they? We have a extension moment. We have gravity trying to move the pelvis posterior. Action reaction would say I need something on the anterior side, that being these ligaments. So again, nice inert structures, energy conserving structures to counteract the extension moment at the hip. So here is, let me just orientate you here. So again, this is a sagittal plane view. We're in the M-L axis. Anterior is over here. Posterior is over here, and you can see that evident by your sacrum and coccyx on the back side. So when we're looking at the hip, you can see that what's normal is the line of gravity falls posterior to the axis of rotation of the hip, but runs through the greater trochanter as a palpatory landmark to confirm this. So the greater trochanter, again, should be posterior to the axis of rotation of the hip. If line of gravity is falling as it shows here, that means that it wants to pull the proximal segment, that being the pelvis, posteriorly. Well, to the right, that shows the posterior rotation. So the posterior rotation of the pelvis, meaning I'm moving in a clockwise direction from this vantage point, creates hip extension. As the hip, if the hip extends, that ultimately is checked by the ligaments over here, the soft tissue ligaments, the iliofemoral, pubofemoral, and ischiofemoral ligaments. All right, moving along, we move up to the SI joint, sacroiliac joint. So our SI joint, the line of gravity should be anterior to the axis of the SI joint, okay? And I can go back to this figure to show that pretty clearly. So here is your SI joint. So here's your sacrum, here's your ilium, so the sacroiliac joint. Clearly the line of gravity is pretty far anterior to that. So what does the line of gravity want to do? Well, here's the new term. So when I said to you earlier that if the line of gravity is anterior or posterior, it relatively wants to flex or extend. There is a new term here, and the term is called nutation. So nutation is a term that's reserved for sacral movement or sacral movement on the pelvis, but it ultimately means flexion. So when the sacrum nutates, it essentially is flexing. So it's not really any different. It's moving forward, but it's just a different term. So if the line of gravity is anterior to the axis, there's a flexion moment or a nutation moment. Therefore, I need something on the posterior side, right? Flexion is anterior, so I need something on the extension or the posterior side. Notice I don't need musculature again. Another great opportunity, sacrospinous. sacrotuberous, sacroiliac ligaments. So ligaments that run from the sacrum to the ischial spine, sacrum to the ischial tuberosity, sacrum to the ilium. They counteract this opportunity for us. Okay, so here we have a demonstration of the sacrotuberous ligament running from the sacrum to the ischial tuberosity. If the SI joint here is in a position to have a flexion moment or a nutation moment due to the line of gravity, it's counteracted by, you can see how this ligament would be tension loaded, right? If the sacrum is trying to go anterior, the distal portion or the caudate portion of the sacrum and coccyx would move superior and posterior. That would ultimately tension load this ligament. Ligaments being tension load resistors will stop or check that motion. So that's just one example. We move to the lumbar spine. Think about the lordotic nature of the lumbar spine. Hopefully it makes sense to you that the line of gravity falls posterior through the lumbar spine. And it really falls typically through the body of the fifth vertebrae, pretty darn close to the axis of rotation. If it's close to the axis of rotation, it has a small moment arm. If it has a small moment arm, there's not a lot of torque generation here, but it's present nonetheless. So we have a posterior positional line of gravity. If it's posterior, it wants to pull the lumbar spine backwards or posterior. That would be extension. And I put the word slight in here because, again, the moment arm is small. So we have a slight extension moment at the lumbar spine. That would be checked by something on the anterior side. Thankfully, once again, we have a ligament, the anterior longitudinal ligament. A very strong, broad, thick ligament running from the anterior vertebral body from one to the next, and also actually has an attachment to the intervertebral discs. If we look at the thoracic spine, the line of gravity now falls anterior to the vertebrae. If we look at not T1 by itself, T2 by itself, T3 by itself, we look at it collectively, T1 to T12, roughly speaking, the apex is around T8. And so because of the kyphotic nature of the thoracic spine, the line of gravity is going to fall forward or anterior to the vertebrae. So if it's falling forward, it wants to pull the proximal segments anterior. That would be a flexion moment. So there's a flexion torque or flexion moment due to gravity. Therefore, we have to have something on the posterior side, again, something on the extension side of the spine, the back side, to stop it. Notice you don't see erector spinae here. Don't need it. We once again can be energy efficient, energy conserving, and use our posterior longitudinal ligament, our ligamentum flavum, our supraspinous ligaments to counteract it. Interspinous could be here as well. I left that off, but you can include interspinous ligaments. All of these inert structures are well positioned to check the flexion moment due to the pull of gravity. Now, when we get to the cervical spine, we have to break it up, as you've learned from Dr. Steen in anatomy, Dr. Schenk, I'm certain, in Clin Med. We'll talk about it soon here in kinesiology, that we break the C-spine up into a lower and upper components. So the cervical spine lower has the lordotic nature to the spine. So the line of gravity is going to fall posterior to the axis, apex being C5. If it's falling posterior to the axis, it wants to pull the lower cervical backwards or posterior. Therefore, we would call that an extension moment. Once again, we have the anterior longitudinal ligament on the anterior margin, well positioned to stop that. Once again, a inert structure on the anterior side in a position to stop that activity. No need for musculature, no need for deep neck flexors to stop it. And then we look at the upper cervical spine, and we have the OA joint and the AA joints, right? So now, as we look at the upper cervical, we're in a slight kyphotic posture. That slight kyphotic posture creates the line of gravity falling anterior to the axis. So line of gravity falling forward wants to pull the proximal segments forward. So that would create a flexion moment of the upper cervical. Now we have the ligamentum nuchae or nuchae, however you pronounce it, and tectoral membrane that counteract it. Fancy terms, fancy names for the C-spine, but essentially are continuances of our posterior longitudinal ligament and our supraspinous ligament. Okay, so you can see here with this line of gravity, you can see that it's dropping down, and this just gives a nice pictorial representation of the spine that we just spoke of. But let's start down here at the hip. You can see once again that the line of gravity is posterior to the axis of rotation of the hip. So just in summary, there's a posterior rotation moment of the pelvis, which is a hip extension moment. That's checked by those strong ligaments on the anterior side here. Pubofemoral ligament, ischiofemoral, and iliofemoral ligaments. If we look at the lumbar spine, you can see that the axis of rotation is close to the line of gravity, but yet the line of gravity is falling posterior. So there's an extension moment of the lumbar spine. ALL here would counteract. Flexion moment of the thoracic spine coming forward. Those posterior structures, ligamentum flavum, PLL, supraspinous, interspinous ligaments are check reins. Lower cervical, extension moment, upper cervical, flexion moment. You can see that a little better here in the upper cervical. If we look at the head, the line of gravity should fall through arguably the external auditory meatus or the tragus of the ear, which is right here. Some would say more formally it goes through the tragus of the ear, this cartilaginous projection, more than the external auditory meatus. Okay, so lastly we come to some pathology and prolonged deviations from optimal posture. So the classic forward head posture, well, what is it? Forward head is a lay phrase, a lay terminology, and it's in quotes. It's a protruded head posture, forward head posture. So if your head is in protrusion, that's going to do what to the upper cervical? It's going to increase what spinal alignment, and also what's it going to do to the lower? Well, if we go into protraction, we're ultimately going to increase the position of the upper cervical into extension. So we're extending the upper cervical and we're flexing the lower cervical. So an individual or a person that perpetually puts themselves in a forward head, protruded head position, over time will have an upper cervical extension and a lower cervical flexion type posture. Well, what does that do? That puts us in a position where our cervical extensors, our upper traps, our levator scapulae, these will ultimately be in a position to adaptively shorten. So we get shortening of our cervical extensors, examples being splenius, splenius capitis, semispinalis. These are going to shorten along with upper trap and levator scapulae, while our cervical flexors will elongate. So our deep neck flexors, longus colli, for example, will elongate. Rounded shoulder posture is another lay phrase or lay terminology, and we'll get to this in more detail when we cover shoulders. Rounded shoulders puts our scapulae in an abducted position, away from midline position, and downwardly rotated position. Okay, so patients that present with this will have muscles such as serratus anterior, pec minor, upper trap shortening, while muscles like the middle trap and lower trap will lengthen. All of what you see here speaks to muscle imbalance. Muscle imbalance is just an abnormally positioned muscle. Muscle could be long, muscle could be short. Okay, so it's muscle imbalance, but it puts us in a posture or position that leads to excessive strain on tissue or deformation of length of tissue, and muscles that are short. So we're compression loading too much on one side, we're tension loading too much on the other side of the spine, none of which is healthy for the spine over time. And really both of these bullets go together. So a forward head and rounded shoulder posture is pretty typical, and they're often coupled together, and you'll see a lot of patients with these pathologies, and you'll address intervention strategies to help them. So that brings us to the end of this talk. Hopefully that was a useful piece and sets the stage for the actual lab, and we'll reinforce all of this in lab this week. Thanks for your attention.